Priyanka Patil would like to welcome our eminent speaker, Dr. Varun Shah, and moderator, Dr. Prashant Khandeparkar, and I welcome all the audience on the Carbetocin in Action webinar. Moving ahead, I would like to introduce Dr. Prashant Khandeparkar, who will be moderating this session. So, Dr. Khandeparkar has completed his MBBS from Grand Medical College, Mumbai. He has done his PG diploma course in clinical research and pharmaceutical business management. He has rich experience of 35 years in different pharma companies like FDC, Piramal Healthcare, and Abbott. Currently, he is a consultant with Hetero Healthcare, and his expertise is, giving medical support to the marketing activities and creating new product ideation. So I welcome Dr. Khandepaka sir, and you can take the session ahead, sir.
Thank you, Priyanka. Thank you very much. Good evening, all of you. Good evening, Dr. Shah. This session, today's meeting is on carbetocin. We all know PPH is a condition which is better read in textbooks and better discussed rather than seen in practice. I remember just one case I have seen in my clinical experience, and my God, I can never forget that case. Expect the unexpected, as they rightly say. And to throw more insights on the clinical insights on PPH and experience with carbetocin, today we have got Dr. Varun Shah with us. Welcome, sir. Dr. Varun Shah is MBBS DNB DGO. Sir is Diploma in Advanced Gynecological Endoscopy from France, Fellowship in Reproductive Medicine, COG, Director and Chief Consultant at Inception Super Specialty Women's Healthcare, Borivali. Special interest, fertility enhancing surgeries, endometriosis, fibroids, and total tubal blocks, infertility management, sexual dysfunction management, urogynecology like urine leak management, prolapse management, early pregnancy ailments, diagnosis, and treatment. Sir has received awards like ISR Youth Icon Award 2023, Times Young Achiever Award, presenter and national faculty in ISR and IHG. Welcome, sir, once again. And sir, I request before we go to the section, actually, this carbetocin has been around the corner for some time. I'm sure you must have used it. Your clinical experience, which is more important to all of us and participating doctors, if you can throw some light on that.
Yes. So, most important aspect is that what we are talking about is management of third stage of labor and prevention of postpartum hemorrhage. So, when carbetocin as a drug was not around, various formulations were available, including oxytocin, ergometrin, carboprost, mesoprost, and people used to use it as per their choices and understanding. But every component came with their own set of limitation and side effects. So people had to really had a hard time what to choose and what not to choose. But since inception of carbetocin, we have used it for quite a long time. Now it is more than 3 years we've been using carbetocin in now exclusively all of our patients. And our experience is that it is a wonderful drug. And for the third stage of labor and prophylactic use in prevention of PPH, it is, according to us and as well as according to now all government bodies as well, including WHO, it is recommended as a first-line therapy. And works wonder in low-risk cases. In some high-risk cases, sometimes you may need a close monitoring. And there is a possibility that you may need to supplement it with some other uterotonics for the prevention as well as cure of the PPH.
Right. And the IM formulation and IV formulation are interchangeably used, or in some cases we prefer IV over IM?
So we are still talking about carbetocin.
Yes, sir.
So we are using exclusively as an IV formulation. We are not using IM because, see, IM is used for the people or the places, it is low resource places where you do not have an IV access, or the cases where the patient has come and delivered and you not even had a chance to, put an IV line. But the places like what we are running where we have everything is in place. So we would always prefer an IV formulation.
And I suppose the heat-stable carbetocin and not requiring an IV line itself is an advantage, especially in the remote interiors where all this could be a challenge.
Absolutely. Absolutely.
Priyanka, yes.
Absolutely.
Priyanka, we could go with the question. Sir, the first question is that when to use carbetocin over oxytocin for prevention of, when to prefer, I will say, carbetocin over oxytocin for prevention of PPH. Can it be used in cases of retained placenta or can it be used in case of Rh negative mothers?
See, theoretically, all cases except the cases where there is a known cardiac problems or cases where there is a known liver and kidney failures. These are three contraindication of not using carbetocin. Rest all cases you can use safely carbetocin. Again, one thing what we need to understand is that carbetocin is recommended as a prophylactic
Prophylactic,
use. It
correct.
is not recommended
Treatment,
as a treatment of
correct,
postpartum
correct,
hemorrhage.
correct.
So when we are talking about active management of first stage, third stage of labor, once the baby comes out, you can immediately give carbetocin IV 100 micrograms as a IV bolus over 5 to 10 minutes time, and it works well. So yeah. Now, when to use carbetocin over oxytocin for prevention? So now, as we have already established that we are now using in all our cases
Correct.
carbetocin over oxytocin, except the cases of cardiac problem or cases
right.
where liver and kidney ailments are there.
In case of retained placenta, it can be used.
And of course, you can use it. Yes, you can use in case of retained placenta, and you can use in Rh negative.
Rh negative mothers. This Rh negative mother question has been coming all around, all in the entire country. The next question is that patient profiles where doctors can anticipate PPH and use carbetocin prophylactically.
Right. So, what we are asking here is that what are the cases where you can
Expect, yes,
anticipate that
correct.
they can end up in a PPH? So, most important is that one thing you have to remember: any patient, whether it is a low risk or a high risk, can end up in PPH. So, always keep your team ready, keep yourself ready, and your protocol should be in a such a way that all your 1, 2, 3, 4, 5 should be in place irrespective of type of the patient. But most important is the patient who have been induced for the labor, patients who have already had a large uterus in terms of either polyhydramnios or patients who had a long labor process, patients who are already anemic, patients who have previous more than 3 or more vaginal births, or elderly patients, or patients are patients with gestational hypertension or the chronic hypertension. They are patients where you can actually anticipate that they can have PPH, and you can use it carbetocin as a prophylactically once the baby delivers, even before the delivery of the placenta.
Thank you, sir. The next question, Priyanka. Can a doctor use carbetocin for prevention of PPH if oxytocin is used for labor induction, which you commonly use in stage 2?
Yes, you can. Now, what we have to understand here is that oxytocin and carbetocin, they are ideally same components
Similar,
theoretically.
yes.
Only difference is that the oxytocin is a naturally occurring hormone in coming from the posterior pituitary and has a little different
Structure.
time of action compared to the carbetocin, which is a synthetic component, but both act on oxytocin receptor on the uterus. So the effect is on the uterus. So the question is that if you have used oxytocin for induction, you can still use carbetocin, because oxytocin, the duration of the action of oxytocin is quite small, the timeline wise, and you can use it, but you have to be a little vigilant, because if you have used oxytocin for induction of the labor, it is fine. But if you have used oxytocin for the augmentation of the labor, and your baby is delivered while the patient is on a oxytocin drip, there is a possibility that all these receptors are saturated with oxytocin.
Correct.
In those cases, it is better to continue with oxytocin. You can just supplement higher doses of oxytocin, and then patient can still have a similar effect. But if just used for induction of labor, carbetocin can be used safely.
Safe. Sir, is there something called as oxytocin fatigue? I mean, we give the drip and after some time the patient stops responding to oxytocin or the receptor. In these cases, carbetocin would not work, as you have said, with the
Yes,
receptors being
so that's
same.
what. So when you have used oxytocin for the augmentation of the liver, you should be vigilant about
Correct.
it. You can still give it, but there is a possibility it may not work, and your second response drug should be there.
Advantage of carbetocin over other uterotonics like oxytocin, misoprostol, carboprost, and methylergometrin, which is used commonly.
Yes. So we have described oxytocin. So
Yes.
let's just understand basic difference between oxytocin and carbetocin. Oxytocin, once you give IV, it acts immediately. While carbetocin, once you give IV, it takes approximately 2 to 3 minutes for its peak effect to come, and the contraction effect lasts for 6 minutes, and the actual effect lasts for approximately 30 minutes.
Oh,
While oxytocin, it peaks immediately, but the effect lasts for approximately 10 to 15 minutes. So there is a difference between the duration. And if same is giving IM, then the oxytocin starts acting from 6 to 7 minutes, and the effect lasts for up to 15 to 20, sometimes 30 minutes. While carbetocin can be effective up to 120 minutes. So this is something what we need to learn. The misoprostol and carbetocin. So misoprostol is nothing but a prostaglandin which we are using, and it has an effect on contraction on the smooth muscle of the uterus, mainly the upper segment. So it can be used. The only disadvantage I would say of misoprostol is that it takes some amount of time to act because we do not have any intravenous or intramuscular formulation available. It has to be given either sublingually, vaginally, or rectally, and it can take approximately, once we give it, approximately 15 to 30 minutes time
oh,
for its action to start coming. Yeah. Carboprost. Carboprost is again a good drug because it can be given intramuscularly. But the only disadvantage with carboprost is that it cannot be used in a patient who have asthma or
asthma.
bronchitis because it causes bronchospasm,
Spasm.
and the patient can end up in a severe bronchospasm after carboprost. Methylergometrin, again, very good drug. The two disadvantages of methylergometrin is that it can be given IM and IV safely, but once we give it causes a strong uterine contraction, and it actually closes the internal os.
Oh,
So what happens is, if at all some amount of placenta which is left behind, or there is a case of retained placenta, you can't use methylergometrin because your placenta is not going to come out at all. And it can also not be used in the cases where a patient is having
hypertension.
gestational hypertension or preeclampsia.
Thanks, sir. Next question, Priyanka. How do you decide? I think you have answered this, when to give.
I think we already
Yes,
answered that
answer.
question.
If the patient is not responding adequately with carbetocin, what would be additional uterotonics that you would use? In which type of patient such scenario may occur?
Yeah, so the type of patient we already discussed. So the type of patient who are already having high risk of PPH. Now the additional protocol what we follow is that if we feel the carbetocin is not having its effect, the first response, if the patient is non-hypertensive, we use methylergometrin,
Okay.
methazine, and we give it IV as a bolus. And simultaneously, we start these patients on uh, uh, intravenous drip of oxytocin
Okay.
with 20 units.
Hmm.
And sometimes, as a third line therapy, we supplement it by either carboprost or
Okay.
misoprostol.
Sir, just a question. If carbetocin doesn't work, oxytocin may work.
It may work because, again, the effect of carbetocin may be short lived. And we are not giving again IV bolus, we are giving
Second
as
dose
an
is not
IV
given.
drip. So,
Correct.
so your first line is methylergometrin, your second line is
Oxytocin.
carbetocin, but simultaneously both can go and it can work.
Where carbetocin is, in which patients carbetocin would be more effective, vaginal delivery or cesarean section, or both?
So theory says that it can be more effective in the C-section cases, but my personal experience works well in both the
Exactly.
patients, and there is no like major difference in either vaginal delivery or a C-section. So you can safely give in both the cases. So I'm personally not aware about the guidelines regarding that, but my personal experience is it can be given in both the
Okay,
cases.
clinicians' personal experience is more important to us, right? The practicing doctors,
Yeah,
finally.
yeah.
Is carbetocin a reserve drug or should be used as a first line for patients with high risk?
Now it is already established that it is a first-line drug for patients with high risk of PPH as well. So without a hesitation, it has to be in your operation theater delivery room,
Absolutely,
and it has to
absolutely.
be given as a first-line therapy.
What is the treatment protocol? I think we have answered this. If carbetocin fails.
Yes.
The next question. What are there any adverse effects, side effect contraindications of carbetocin or oxytocin and other uterotonics? You say that
So, yes. So antidiuretic effects, water retention mainly. And so because of that, the liver and kidney, if they are not functioning properly, or the heart is not functioning properly. Cases where there is a severe anemia, cases where there is a impending failure of heart. These are the cases where you can't use oxytocin or you can't use even carbetocin. So these are the cases where you have to resort to your second line therapy. Methyl ergometrin, misoprostol, or carboprost may work, but again, your operation theater and your staff and your uh, uh, support system should be ready that this patient can also require operative intervention, blood transfusions,
absolutely.
and the most important point is that you have to take decision very
On the spot,
fast.
yes.
Because sometimes we contemplate in operation theater ke, oh, ho jayega, and in that you lose so much blood and time. The patient deteriorates so fast you can't even imagine.
How common or how severe is this ADH effect of carbetocin as compared to oxytocin?
It's not very common. In fact, I'm yet to see, because see, since we are all giving a prophylactic dose and it is just a one dose mostly most people are giving, so the ADH effect will not be that prominent. Um, Oxytocin in can have that, because so many times oxytocin is used as an IV drip for a
Correct.
long period of time, and it
More of
can have the ADH type of effect.
more of
But
drug is.
theoretically, both can. Yeah.
And to conclude, efficacy, safety, tolerability in your experience for carbetocin vis-a-vis other uterotonics.
So quite effective, and specifically for the low risk cases, quite effective. So I would say 90% patients do well with just a single shot of carbetocin. Safety wise, quite safe because side effect profile is not there, and whatever contraindication are, they are also quite limited. Tolerably, highly tolerable drug, and yeah, so I think we found our answer.
Yes. It will be good to use something prophylactically and avoid a potential disaster. I
Absolutely.
think that was all, sir. Thank you so much. And thank you so much for
Thank
giving
you,
this
sir.
clinical insights. And I thank all the participating doctors who took time from their busy schedule and commitments and attended this session. Thanks, marketing team Heathrow, for conceptualizing and organizing this webinar. As you'll all agree with me, this type of program requires super coordination. Thank you, Heathrow field personnel, for an excellent course of coordination. Last but not the least, thank you, IT team Heathrow, for your support and guidance. Once again, thanks to all of you. Wishing you a very good evening and signing off. Thank you, sir.
Thank you.
Thank you.
Take care.
Thank you,
Thank
sir.
you for inviting.
Thank you, sir.
Priyanka, can I leave the meeting now?
Yes, sir. Yes, sir.
Yes, sir.
Okay.
Okay. Thank you so much, sir.
Thank you. Bye bye. Take
Bye.
care.